So, good evening. I'm hoping you can all hear me, and welcome to tonight's primary care seminar hosted by the Primary Care Education Department at City St George's, University of London. My name's Lucy Williams and I'm a GP and clinical lecturer here at City St George's. I'm joined by members of our primary care team, Dr. Adam Thomas and Vanessa Silu, and our student partners Rachel and Zara, who have supported in developing and delivering this. So this seminar is the second of this year's primary care seminar series, which is in its third year, aiming to showcase the diverse opportunities available within a career in primary care to both students and professionals alike. The seminars have been co-created with our students, so medical students and also students from other allied healthcare courses who have been the driving force behind these events. It's through their input and passion that we're able to explore a variety of topics within the field and highlighting the vast potential a career in primary care can offer. So tonight's topic, chosen by our students, focuses on an incredibly important issue in primary care and is particularly timely in the winter months. So we're talking about antibiotic use and stewardship in primary care for respiratory tract infections, what works and what next. So to help us navigate this, I'm delighted to welcome tonight's speaker, Professor Paul Little. Paul has been a GP for 20 years and is a Professor of Primary Care Research at the University of Southampton. He's a Fellow at the Academy of Medical Sciences, an NIHR Senior Investigator and winner of the Maurice Wood Award for Lifetime Contribution to Primary Care Research. So he's perhaps best known for his research on prescribing to address one of the major global threats to public health, antibiotic resistance. So we thought who better to ask than to help us navigate this today. So Professor Little will speak for about the next 40 minutes or so, and then we'll have a Q&A. So please use the Q&A box to submit any questions or comments, and we'll put them towards Paul at the end. So without further ado, I'll now hand over to Paul.
Great, thank you very much. Now, can I work the share button again? Yes, hopefully I can. Tell me if the slides come up.
Hopefully it is loading.
Yep.
Yes, we're in action.
Brilliant. Okay, so I'll just kick straight off. So I'm going to be talking largely about communication and understanding. So, these ladies come on a Friday, they might be a bit disgruntled. They had antibiotics last time and they might want antibiotics this time. So how do we understand where they're at and how we can help them? So I'm going to take you through the patient journey, if you like. Firstly, prior to the consultation, can we reduce antibiotic use by preventing infections or shortening the illness? In the consultation, what does judicious prescribing look like? I'll give you a summary of the evidence base for antimicrobial stewardship interventions, and if I've got time and haven't been droning on for too long, chat briefly about where next. Okay, pre-consultation, can we prevent infections? So I'm going to take you back to swine flu, and much though I love pigs, I wouldn't want to get quite this close to them. So at that time, there was a lot of chat about hand washing, very widely advocated, but it was still pretty hotly debated. And the reason for that was that the Cochrane review showed that there was really no good randomized evidence among adults in non-deprived settings, in other words, our setting. Hence, the drive to understand and try and develop an intervention that these ladies might consider using. So the MRC primate trial, so to develop and trial an internet-delivered behavioural hand-washing intervention that could be used widely, we call the intervention germ defence. We use something called a person-based approach to develop it. It's a user-centred approach. Basically do in-depth qualitative work to understand and address key behavioural issues, and then you iteratively develop prototype to ensure that what you've developed is engaging and is likely to change behaviour. Then once you've developed it, onto the trial, which was in 20,000 odd folk, followed up over one winter season. What did we find? Basically a really nice reduction. Just this was a freestanding website, so people didn't have to use it. So they were obviously willing to use it. And what we found was a 15% reduction in respiratory tract infections in the population, the randomized population. 10% reduction in the days of more severe symptoms, 25% reduction in transmission of infection from the index to the household, and a 15% reduction in transmission from the household to the index person. 10% reduction in consultations, which is pretty important for our GP sanity. 15% reduction in antibiotic prescription. That's again really nice for such a brief intervention. And as you might expect for a hand washing intervention, 20% reduction in GI infections as well, although that wasn't our original target, but you would expect it to do that. Very mild harm, so mild skin irritation, about 2 to 3% more in the intervention, which obviously you can use emollients for if you do get a mild skin irritation. So the big question with trials is always, you know, can you really believe trial results? What happens when you use them outside of trial context? So during COVID, we had a chance to see how it might be working, looked at about 30,000 users of the website. And basically what we found was that after using the germ defense outside the trial context, the change in intentions to hand wash, which then predicts hand washing, was actually almost identical to the original primate trial. So what we feel is that the trial results are actually quite likely to be generalizable, which is good news. Okay, next are, can we reduce illness duration? Now, this is one of the nicest trials I think we've ever done, and perhaps the most useful for practice. If I can get it to move on. Yes, I can. So this was published in the Lancet Respiratory last year. 14,000 folk randomized to usual care, saline nasal spray, Vicks first defense nasal spray, or a website supporting stress and physical activity. The sprays, you can get these down the chemist. Anybody can go down the chemist and get these. The idea was that you do the first sign of any illness, any respiratory illness, so first cough, first tickle in the nose, whatever, or just feeling unwell and you think you're developing something, 2 sprays in each nostril up to 6 times a day at the very first sign of illness. And we asked people also to do it after they've been heavily exposed to somebody, but in fact they didn't do that very well. So this is really evidence for first use early in the illness. What do we find? 20 to 30% reduction in illness days in the spray groups, which is pretty phenomenal for such a simple, cheap intervention. In terms of prevention, the sprays, because people didn't largely do the behaviours we wanted them to, didn't prevent. But the website did. A 5% reduction. Is your glass half empty or half full? 5% reduction for public health terms is actually pretty big. So we were really pleased with that. Freestanding website again. Work days lost. 20 to 30% reduction of work days lost with the sprays. Fantastic result. And even more fantastic, reduction in antibiotic use with the sprays of around 30%. And with the website for about 25%. So these are fantastic results, simple stuff you can use in your consultations. So if you see somebody and particularly if they're prone to infections, tell them to go down to the chemist and use it. I would use a saline spray because Vicks had a slightly higher incidence. They're both well tolerated, Vicks slightly higher incidence of headache. Next, can we improve self-management of symptoms and reduce consultation pressures? So this was the Internet Doctor trial in 33,000 folk. Again, we developed the website using this person-based, user-centered approach. 2 groups, usual care or the Internet Doctor website. And the website wasn't rocket science, tailored advice about diagnosis, natural history of infections, simple things about symptom management, particularly using paracetamol. We did actually advocate ibuprofen use, but I really wouldn't do that now. If anybody wants to talk about that later, happy to do so. It's not good news for infections or anything else, I think. And then after last year, went to seek further help. What did we find? We found, well, firstly, 50% of folk had an RTI over the 24 weeks. A very small increase in NHS direct contacts with the intervention, 1% increase over control, but actually a much bigger, more important reduction in doctor contacts, about a 4% absolute reduction, 30 to 40% relative reduction, which is again a big effect in practice. And perfectly safe, reduced hospitalizations. Now, you don't need access to the Internet Doctor website to be able to say to people, actually, there's good advice out there, actually on the NHS sites about how to manage your symptoms. And this is going to help them not come to you quite so often. And it's a safe thing to do. Okay, so what about in consultations? So I'm going to be talking about the benefits and harms of antibiotics that we commonly prescribe for the most common respiratory conditions we see: otitis, sore throat, sinusitis, and bronchitis. So I'll just go through each of these columns in turn. So the prior duration of otitis, 1 to 2 days, sore throat 3, sinusitis 5, bronchitis 10. These are averages, so there's a whole range around this. Duration after the consult between 3 and 5, 5, 7 to 10, and 10 days. So you get a total duration of about half a week on average, a week, 2 weeks, and 3 weeks for the 4 conditions. From our trials, we've done trials in all of these areas. What benefit have we found? And these are pragmatic primary care trials. Basically, a benefit of a day or less than a day. Perhaps the biggest effect was in otitis, but by day 3, the illness was mild. So you save a day of mild illness, maybe, and the pain throughout the first 2-3 days of the illness, which is the most painful, the pain was equal antibiotics versus infection with delayed prescription. So basically, our trials have found very little benefit. What does Cochrane say? Well, those are number needed to treat to prevent illness at between 3 days and a week for most of them. So otitis, NNT of 20, sore throat between 5 and 6 at day 3 and 18 at day 7, 19 for sinusitis at day 7, 11 for bronchitis. So actually not too dissimilar to our pragmatic primary care trials, but Cochrane will have included secondary care trials as well. So do antibiotics help symptoms in respiratory infections for uncomplicated illness? Not much, I think. So, but what are the harms? Because obviously you benefit, there might be some mild benefits for uncomplicated illness, not much, but you have to balance whatever benefit there might be against the harms. So medicalization, what do I mean by medicalization? I mean that if you prescribe something, are you increasing the belief in that because you prescribed it? And so this is an old chestnut now, just shows how long I've been at it. 1997, the sore throat trial. 3 groups: antibiotics, no antibiotics, or a delayed antibiotic. In fact, we asked people to pop back for this, but there are any number of ways you can delay an antibiotic prescription if you want to use the strategy. What did we find? No difference in how quickly people got better, no difference in satisfaction with the consultation. But if you prescribed an antibiotic, you hugely increase belief in antibiotics for the index person, and hugely increased future intention to consult. And when we followed this cohort up, there was a 40% relative increase in consultation rate for the people who've been given 1 antibiotic prescription. So you hugely created this belief system, goes out to old Auntie Nellie and cousin Richard. So they all hear that actually you had an antibiotic and I'm better now. And what's happening is people attribute getting better to the fact that they've had a prescription. What is there any other evidence for medicalization? Well, we found the same thing in our trials, but also there's some lovely data from Mark Ashworth studies in London practices. So what he found was that higher antibiotic prescribing practices had higher consultation rates for respiratory infection, and if those practices reduced prescribing over time, they reduced their consultation rates. So it's not just our trials. So is this what we're doing? I think for symptoms, it is largely what we're doing. If you prescribe, somebody comes with symptoms and you prescribe an antibiotic, people believe it's the antibiotic, but in fact, it's just the illness getting better. And that's why they got better. And they come, they get more, and they go on believing antibiotics. And obviously, you've got to balance that against other harm. So that's the harm that we're doing to patients because they're getting unnecessary antibiotics. It's the harm to us because we're getting more consultations. So there's several harms involved there. But the biggest harm is antimicrobial resistance, which is a public health emergency on the par of obesity, climate change. It's that sort of seriousness. The WHO has been pulling no punches about this. Resistance to antibiotics could bring the end of modern medicine as we know it. They've said that as long ago as 2012. That's because you need antibiotics for infective complications of illness, surgery, cancer treatment. They all require antibiotics that work. But is it our problem? Is it animal use. Well, we exceed animal use, but that is an issue. It has to be tackled across sectors. But yeah, we are doing most of the prescribing in the health sector. Around 70+% is us prescribing. And does our prescribing make a difference to resistance? Well, this is clear. This is at a national level, showing a clear relationship between outpatient use of penicillins and resistance rates at a national level. And what you don't want to be is, I'm not sure you can see it there, France is at the top there. You don't want to be in France getting a bug and being an attempt to treat it. Do want to be in the Netherlands. We're not doing too badly, but actually we all want to be where the Netherlands are, I think, to be fair. So that's national level evidence. Is there evidence at an individual level? Well, yes, there is. So this is a systematic review of antibiotic exposure and AMR measured in the individual after at least 1 month, 240 studies, and a pooled odds ratio of 2. So you're twice as likely to harbour a resistant organism if you've been given an antibiotic. And what about the problem for the future? Why is this such a huge public health problem? Well, the World Bank has estimated, I mean, all estimates, can be critiqued, but they reckon there's probably going to be about 1% annual loss in GDP, much more in low and middle income countries by 2050, equating to a huge sort of dollar equivalent up to $200 trillion lost to the world economy. Deaths are likely to outstrip many causes, whether it's quite as bad as the World Bank thinks. But anyway, this is what they think. The purple wedge is AMR deaths projected to 2050 and outstripping pretty much everything else: cancer, cholera, diabetes, diarrheal disease, etc. So this is a huge public health problem that we all have to own. What we've thought is that if you cut down antibiotic use, it's all going to be nicely reversible. So we don't have to worry too much. We just have to cut down antibiotic use at a public health level. We probably shouldn't be quite so complacent. So this is a sort of review of the 7 large studies of interventions in the community. So community level reduction in antibiotics, what happens to resistance? So there's the 7 studies. And in 3 of those studies, despite a good change in antibiotic use in the population, there was either no effect or an increase in resistance. In the other 4, there was an effect. So I don't know, is 4 out of 7 good? I think actually it's not great news that if you can't assume that you're going to reduce resistance. Still worth trying, because 4 out of 7 is better than 0 out of 7. But why is that happening? I think it's because the bugs are clever. So we've normally said an antibiotic resistant bug has a selective disadvantage because it's got an extra bit of genome that slows it down in its replication. But in fact, they've got clever ways of getting around that. So I think the fitness cost of resistant is not as big as we thought it was. So we can't be complacent about this. Big thing for us and our patients: can we safely reduce antibiotic use? I think that's the nervousness of clinicians. It's also the nervousness of patients. But it probably is reasonably safe. So this is Martin Gulliford's rather nice study. I shouldn't say that because I was involved in it too. But anyway, 610 general practices relating antibiotics prescribing to complications. So what they worked out was, in a general practice of 7,000 patients, if you reduce prescribing by 10%, you get 1 more case of pneumonia each year, which is perfectly treatable. 1 more case of quinsy every decade, again, which is treatable, but you could always admit somebody if they really do need it. And none of the real nasties, mastoiditis, intracranial abscess, Lemierre's, were higher in the low prescribing practices. So it looked like, at a pragmatic practice level, it's reasonably safe. Okay, so what can we do about it? What actually works to reduce antimicrobial use in practices, in general practice? First of all, delay prescribing, otherwise known as wait and see. Sorry, it's a terrible dad joke, but hey, I do terrible dad jokes. So about a 34 to 76%, depending on so that's the range really, compared with immediate antibiotics. If you're thinking that you're a high prescribing practice, you will dramatically reduce your antibiotics if you use delayed prescriptions. Compared to no prescribing, actually delayed prescribing, as you might expect, is slightly higher. So the trials say anyway, 14% in the no versus 28% with delayed, but actually getting down to 30% antibiotic use is fine. We'd be doing very well if we did that. There are some advantages of delayed prescribing. It is quite a useful thing in practice, I have found anyway. You don't have to do it. You pick your patients if you like. So this is an IPD, an individual patient data meta-analysis, 9 trials, 4 observational studies, basically showing symptom control was really good compared to immediate antibiotics. There was much less reconsultation compared with no antibiotics, about a 30% reduction, so you're saving yourself consultations. Increased satisfaction compared with no antibiotics, and it's probably one of the most cost-effective things you can do if you do it properly. What do I mean by doing it properly? Well, just giving it to the patient saying, "I just wait and see," it isn't probably good enough. This is mostly good consultation practice. So we've divided it into the 6 R's. So reassure somebody they do not need antibiotics at the moment. Give them reasons not to use the antibiotics, side effects, allergy, and AMR for them and their families. Give them information about how they can control their symptoms, particularly paracetamol. I wouldn't use non-steroidal unless, well, occasional use perhaps at night with badly controlled symptoms, but I wouldn't use them otherwise. We can chat about that later if people want. Give them the realistic natural history. This is absolutely crucial. If they have no idea how long it's going to last, of course they're going to be back and demanding antibiotics or something else. So you need to remember the natural history. So I think of it as half a week, 2 weeks, and 3 weeks for those 4 conditions. But you can think of it as the average duration after the consultation, 3, 5, 7, 10 days. Doesn't matter if you can argue about exactly what it might be, but those are reasonable ballparks to use in practice. And I always reinforce the key message. You only use this prescription if you're getting significantly worse or not even starting to settle in the expected average time that I've just talked about, if you like. And then you need to give for all, we're in a terrible position in primary care. We're hiding to nothing. We see things at an early stage, so always give people safety netting or rescue advice. That was just basically good consultation technique. It's not difficult to do that. It doesn't take that much more time, maybe a minute or so more, but probably not even that once you get used to talking to patients about it. So what else works? So this was the Agency of Healthcare review, American organization. They looked at 26 interventions and came up with 3 or 4 recommendations. Actually, it was 5, I think, anyway. Patient and clinic education outside the clinic, education in the clinic. So that's us in our clinics. Actually, you can have quite a big effect, either verbally or using booklets to support. These are reductions in antibiotic use. Public health campaigns, actually, they can be reasonably effective if well done. Electronic support systems. So I'll give you an example of one of those later. In fact, there's several, because I think this is potentially useful. They're quick to use, and you can get quite meaningful reductions in antibiotic use. Near patient tests, and a really useful thing to think about, or I think the jury's a bit out on those, and I'll discuss why later. This particular review recommended procalcitonin because the primary care trials had shown up to a 72% reduction, but I'll explain why it's a crap test and you shouldn't use it in a minute. Streptococcal RADTs, well worth thinking about. So these detect strep in the back of the throat. If it's positive, you want to think about maybe an antibiotic will help, maybe. Rapid viral testing, there's progressive evidence about that, small effect. At the moment, I think really the jury's out on that one as to whether it makes any useful difference. And C-reactive protein for chest infections, possibly other infections, really quite a nice reduction. So that's probably the 2 best bits of evidence there are streptococcal tests and CRP. Okay, I'll go into that in a little bit more detail. Firstly, I'll say why you shouldn't use procalcitonin if it comes around. It's not pragmatic, at least the trials that show that it worked were not pragmatic. 2 tests over several days. Who wants to do that? Not me, not most GPs, I think. Also, it's just not validated in primary care settings. The reason it reduced antibiotic use is because it has a low positivity rate. Why is it crap? This is why it's crap. So this is to detect pneumonia. If you want to detect pneumonia, which is the biggest complication of chest infections, this is a ROC curve plotting 1 minus sensitivity against 1 minus specificity against sensitivity. A good test will be up there in the left-hand corner, perfect test. A crap test goes along the black line. So what do we find? This was in the very large GRACE study that we did. Symptoms and signs does pretty well. That's the solid green line, not bad. Procalcitonin doesn't add anything to symptoms and signs in terms of predicting pneumonia in primary care. That red line was CRP, so CRP was doing a bit better. So the lessons here are that if you use an expensive, unpragmatic, invalid test with a low positivity rate, it will reduce prescribing, but it's a silly thing to do. So use a good test, and it needs to be realistic for primary care. Okay, so training to use other near-patient tests is prompting, particularly strep RTIs and CRP. So those are the two things I think to think about, whether you want to use them. Key questions for me: does the impact increase with co-interventions? So we're talking about communication training. Does the impact last? And is using a near-patient test better than some of the alternatives, like using clinical scores or decision aids? Okay, so we had tested some of those key issues, I think, in something called the GRACE intro trial. So we developed enhanced communication modules, and this wasn't, so it's over 9 months using this person-based approach I've described before. In 6 countries, and the training module actually was pretty pragmatic. It took GPs less than 30 minutes to work through, and 3 elements. None of this is rocket science. So addressing the patient's world, concerns and expectations. The reason why that's incredibly important is because we commonly misattribute people's worry to desire for antibiotics. What people commonly are worried about, in my experience, and I think that the literature supports this, they're worried that there's something horrible going on. So you need to reassure them there's nothing horrible going on, and they may have expectations for antibiotics because they've been prescribed antibiotics before. Information exchange, that can be really helpful. There's good evidence for that. You can either use a booklet if you got them, or there are lots of leaflets, target leaflets available. The one we used outlined the natural history, risks and benefits of antibiotics, self-help measures, and safety netting. So pretty much the range of stuff I talked about for delayed prescription. So this is standard stuff that you can do in any consultation. And then there was a wrap-up section. So a fairly commonsensical intervention for communication. So this was the trial, big multinational trial. I'm not going to go through the diagram. 6 countries, 200 plus practices, 4,000 plus patients, 4 groups. So communication training, yes or no, training in CRP testing, yes or no. So if you had neither, 60% got an antibiotic. If you had CRP testing, you reduced antibiotic prescribing by a half. If you had communication training, you reduced antibiotic use by around a third. And if you had both, you reduced it by about 60%. So fantastic results at a year or the first season. Does it last? Okay, so this is a year on, or another season on. So unfortunately, CRP effect pretty much vanishes, but not communication training, interestingly. So usual care basically had reduced their antibiotic prescribing a little bit from 58 to 51. The training in CRP had actually got slightly worse, gone from 35 to 43. Communication training had actually stayed about the same, so the effect was still there. But if you added communication training to CRP, you didn't do any better than just communication training alone by a year. So really a bit disappointing, I guess, but actually the good news is that communication training is well worth doing. And there's been a Dutch trial showing the effect of communication training, and last years, 4 to 5 years, they've done follow-up. So it's a really simple, nice thing to concentrate on. So the lessons: the effect of training in the use of near-patient tests may well wear off, even when you're using a valid test like CRP. And the effect of training in communication skills probably doesn't wear off, which is very good news. Okay, I said I'd talk a bit more about clinical prediction rules, which I think can be very useful to use in practice. I'll talk, probably the example we've done is something called fever pain, which some of you may use in practice, I don't know. What is it? Fever in the last 24 hours plus on the tonsils, attending rapidly, but you can actually substitute muscle aches for the A if you want to. Severely inflamed tonsils and no cough or coryza. So this is a pharyngeal illness. So streptococcal illnesses are pharyngeal illnesses with no cough and not much snuffle. And if you give each of those 1 point, as the score goes up, so does the risk of streptococcal infection. NICE have endorsed this, and it's in lots of GP systems now too. Why has NICE endorsed it? It's because actually there has been a trial, which is the trial we did, the fever pain trial. What was that? Delayed antibiotics, clinical score, or rapid antigen detection test group. So the clinical score was basically, as the score with fever pain got higher, you either had delayed antibiotics or immediate antibiotics. The rapid test group, basically you still use the score, but if the score was 3 or more, you were asked to do a rapid test and then treat if the test was positive. What did we find? So the clinical score group compared to delayed prescribing reduced severity by about 1/3 of a point, which actually for the whole population was significant. 30% reduction in symptom duration, which was a staggering result, really. And then a 30% reduction in antibiotic use. So really nice results with just using a clinical score alone. If you used an RADT as well, so that's the third group, there was really no extra benefit over and above using the clinical score alone. So no real justification for adding in a streptococcal test there, I think. The lessons: using a near-patient test may not be better than using a clinical score alone. But I do think we need to trial more clinical scores and decision aids. I think that they're very useful to use in practice potentially. And I think we need to trial a wider range of near-patient test strategies. For example, you could say, don't ever give somebody with sore throat an antibiotic unless you've done a near-patient test and shown that it's positive. I don't think that strategy has been trialed yet. What about other decision rules? Well, there's a whole host out there. So I'll just quickly mention them. So adults with LRTI, there's children with LRTI, there's sinusitis, there's otitis, and there's UTI. So actually what we'd like to do, and we've started to develop the tools, is to put these into some kind of tool that GPs could use in practice. And it's modeled on the same kind of approach that we used in fever pain. So it's based on trying to use an electronic decision aid to target either no, delayed, or immediate antibiotics, depending on the score of the decision tool. And what you have is a list of conditions. You choose which condition you're using, you put in the clinical information, and then it gives you an output that you can negotiate with the patient, just like we did in the fever pain trial. So I think we can say management strategies are rather complex behaviors. And I think all of our interventions that we've developed, including, if you like, simple near-patient tests, you really do need to understand and address the key behavioral issues for patients and prescribers. And so many trials that try and address behavior change for patients, if you like, and or doctors, don't address the key beliefs and behaviors. There are, I think, really nice, effective pre-consultation interventions for respiratory tract infections. Hand washing, I mean, it was important in the pandemic. It's still important now. When we trialed the Germ Defense website, it turned out it was outside the pandemic. It will work now. So advise your patients, particularly if they suffer from respiratory infections, to still take hand washing really seriously, particularly as the flu season and RSV season get going. Self-management works. So at the moment, I think the NHS advice is pretty good and would encourage patients to use that. A website to reduce stress and increase physical activity works. We will try and make that available in some form, but being aware that that's important for your patients, I think, is something you can discuss with patients. And we've got really nice evidence for the use of saline nasal spray in particular, but Vicks First Defense works pretty well, although it does give you slightly more headaches. But nasal spray is easily available, cheap, could be widely used in the winter pressures. And I think there are effective consultation interventions as well. So decision aids for fever pain we've shown is effective. Diagnostic test strategies, but they do need to be valid and pragmatic for primary care. I think patient-doctor communication clearly is important. We may think we all know it, but key things there, I would say, are making sure that you understand really what the patient concerns are, and you can negotiate lower antibiotic use. And it's not rocket science, and you need to particularly discuss with patients what the natural history of their illness is and what likely benefit they might get, particularly if it's uncomplicated illness. I think delayed prescription does work if used properly. I think it's clear that national level interventions also have a real role, and they can be effective in reducing antibiotic use, but we can't be complacent that they will always reverse AMR, which is one of the reasons why it's incredibly important to use simple things like the nasal sprays. Where next? Well, we've got much less evidence for UTI, so I think strategies there need to be better researched. I think we do need more evidence for key pragmatic things, so more evidence for the long-term impact of using near-patient tests. I think the jury is out on a lot of those at the moment. If GPs can't or won't use them, which is what we found in the Grace Intro, we gave them free access to CRP, free kit, free everything. And after one season, they just didn't want to use it. And I understand that. I mean, I'm not a great advocate of near-patient tests personally. I like to manage things clinically. So, but pharmacists might well, if they're more structured in their use, might well have a longer-term effect. I think decision aids can be incredibly useful. But we need to validate and look at the impact of a range of them. You could say, well, actually, we know enough about a lot of these to implement them. So particularly sprays, websites, delayed prescribing, and communication training. And I think we definitely, as well as we've got fantastic evidence for saline used early in the illness, but I think we also need evidence for alternative treatments. I can't wait for some of the phage research to come online, because I think that could be incredibly helpful. And I think you've had enough of me, but I don't know whether you've got access to beer. Anyway, you're welcome to have a beer.
Oh, thank you so much, Paul. That was really interesting. You've made antibiotic stewardship and all your research so fascinating. We've got some questions coming in. I've also got loads myself, but I will hold back on that and hit you with some comments first of all. Actually, just on the back of what you're saying about you can't underestimate the value of like the patient concerns and expectations. And Gordon here has just said, something I found helpful over many years in practice as part of the consultation is what should we teach? Ask about ideas, concerns, expectations. You may be pleasantly surprised how many patients say they want reassurance and don't want antibiotics. So there's no need to move into persuasion mode.
Yeah, absolutely. Because once you unearth it, your sense of pressure, they want an antibiotic, often vanishes. Because they're just, is something horrible going to happen, doc? What are they really worried about? And if they do think, well, if they say, I really want an antibiotic, you can say, well, I know we've used to prescribe them. What we found in your situation, because usually you've taken the history and maybe done an examination, hopefully, you'll say, I can say, actually, you aren't somebody who's going to benefit. Honestly, you're going to get disbenefits, which are the following. So I think, but unless you unearth it, because they may not be wanting antibiotics at all, in which case you don't have to go into persuasion mode. Yeah, quite right.
We've got another, just a quick one for anyone if their hands up, if they can try and pop them in the Q&A, that'll be better. We found than trying to unmute people, if that's all right. We've got another question from Sue, who says, I may have missed this, but what duration or course of treatment? So can shorter courses be as effective?
Yeah, most of the evidence suggests they are, although short courses aren't necessary for most of these infections. So if you've got a pneumonia, probably the evidence is a 5-day course is fine, but I'm always a bit nervous about just our main priority has to be the uncomplicateds. The complicateds, don't worry about them. But if you're going to use an antibiotic for the uncomplicated, use a short course. Yeah. There's pretty good evidence there, but I would encourage you not to use an immediate antibiotic of any kind if you can. But yeah, the evidence about short versus longer courses is that short works pretty much as well.
Good. Okay, so moving on, Kerry has a question. Are there some subgroups of patients where these interventions may work differently? For example, people with comorbidities or who are immunosuppressed?
Yes, comorbidities are at higher risk. But again, if they've got uncomplicated illness, we haven't really shown that there's a great benefit there. Immune suppression is a different kettle of fish. I think, we haven't done big trials in immune suppressed people, but so I would be much more cautious there because they're much more likely to, I mean, the issue is, so you can either be a bit more generous with antibiotics or have a much lower threshold for seeing them, saying at the first sign of any problems, do come back and see us. So they are a different category. They haven't been well represented in the trials we've done. So I think we can't apply this evidence to them. So I'd be much more cautious about them. People with comorbidities, it depends, it depends on how many comorbidities, how frail they are. But most of the people who take part in trials aren't that frail. Really frail elderly probably haven't got into many studies, to be honest. So, and again, I wouldn't worry about them too much. They will be at high risk from infections. So I'd do the same as with the immune suppressed. If you've got somebody who's very frail in front of you with lots of comorbidities, fine. You can always use a delayed prescription if you think they could manage that, or have a very low threshold for seeing them again.
Yeah.
But I wouldn't worry too much. If you want to give an antibiotic to somebody who's frail, elderly with massive comorbidities, I wouldn't worry. It's the younger group who basically have when I say younger, I'm talking about under age 70, which is the most of the people we see aren't going to benefit if they've got uncomplicated illness.
Yeah. Catherine's got a good question. I was thinking about this as well with interprofessional sort of learning, especially as more community care, we're using pharmacists, paramedics, physicians associates. So along the same lines, Catherine has asked, it seems to me there is the space to implement training in near point of care tests in pharmacies, particularly for UTIs. What are your thoughts on this, or perhaps more broadly interprofessional training?
Yeah, no, well, it's interesting you should say that. We're running a study called Phased In, which is basically providing that list of decision aids that I showed you that we've developed into an app for pharmacists to use. At the moment, as you know, there's a whole range of stuff that they can use, but they're really left in limbo because they haven't got any decision aid really to help them. So I think it might be incredibly useful for pharmacists to use decision aids. This is confidential because the results aren't out yet. In our piloting, the future of pharmacy prescribing of antibiotics is that they become independent prescribers like GPs, not with patient group directions, which are very restricted. And those are the pharmacists who use the independent prescribers, who actually did behave rather like GPs. They often just went their own way. I'm speaking against my tribe here, but anyway. So we've still got some work to do with pharmacists, but there was a 10% reduction in antibiotic prescribing, even though they didn't really do what we wanted them to do. So we've got more work to do there. But I think they love the decision aids because they weren't so much in limbo. So even though they didn't necessarily do what the decision aid said, they felt it was very useful to have them there, and they could then make a decision based on at least in part the decision aid. So more work to do there, but I think pharmacists will be helped, and they will be getting more and more management of these infections over time, I think.
A couple of people have asked, so Pippa, and I think I saw somewhere else, Tess was also asking, can you tell us more about why we shouldn't use NSAIDs or ibuprofen?
Oh, sure. It's largely observational evidence. So So when you get any respiratory infection, particularly a chest infection, you have an increased risk of heart attack and stroke. It's not huge, but it's there. In the week or so after the consultation, it's there. You've increased the risk. If you add a non-steroidal, again, this is observation, you increase the risk further. Plus, you've got all the other side effects of non-steroidals, particularly in the frail elderly. You don't really want to be giving them a non-steroidal. Plus the fact that actually they don't work that well. And there's also concern from some of it's making inferences. So in UTI, the studies that have involved ibuprofen have had higher complication or Voltarol have had higher complication rates than placebo. So there's concern that the non-steroidals impair with the body's inflammatory response, which is part of the response to infection. So not only is there observational evidence, there's indirect evidence from looking at some of the trial data sets, and there's the worry about, what are these drugs doing when they're not probably doing that much for symptoms. Having said that, they probably do a little bit. So what I'd advise is, certainly my wife has found non-steroidals incredibly useful on the odd occasion. So I advise her, don't use them, because all of the trials, when they've looked at non-steroidals, have done regular use of non-steroidals. So what I would say is, if you want to have a better night's sleep and paracetamol isn't working, take a non-steroidal at night, but don't take it regularly, for God's sake.
Yeah, that's really good advice. Yeah, I was just thinking about all those. I'm sure we looked at lots of Cochrane reviews when I was a student about paracetamol combined with ibuprofen and then alternating with parents. So yeah, good advice going forwards. Kind of along the same lines as the ibuprofen, we've had a few people ask about how do the saline sprays work?
Hot.
Yeah.
Yeah. So this is fascinating. So I was really a saline ignoramus, I have to say. So I thought that if they worked, they'd be working by flushing out viruses, which is plausible. But when we published our enormous trial, an Aberdeen virologist got in touch because he's done some work on how saline might work. And what saline does, and I think it's much more plausible than the washing out theory, is the chloride in saline is taken up by the lining of the cells in the nasopharynx. It's converted to something called hypochlorous acid, which inhibits viral replication. So I think it's a natural antiviral. That's how it's working. He's shown that hypertonic saline is probably more powerful than isotonic saline, which is what we used in it. So even though we used the wrong saline and people didn't do what we wanted them to do, it was still effective. So saline, I think, is the best thing since sliced bread. I think it's fantastic. So I would use, if you see people and they're troubled with respiratory infections and you want to do something that will make a difference, I'd use saline. Particularly for those people who, they're troubled by respiratory illnesses and they're getting recurrent respiratory illnesses. Tell them to get some saline and to use at the first sign of an infection. They'll have shorter illnesses, less severe illnesses. They'll use less antibiotic use, and they'll come back and see you less.
Very good advice. I kind of assumed, I'll be honest, my mum, or whenever I go see my little niece, who's often, got lots of coughs and colds, we'll pop the first defence in before we see her. Quite literally, I just assumed it was first defence, but I had no idea about that other sort of mechanism of how it might work as well, or at least the saline.
So Vicks has two mechanisms of action. So it has a polymer, which mops up viruses, and it has an antiviral bit which lowers the pH outside cells. But it didn't work any better than saline. And although the headache wasn't that common, it was, I think, 4% in usual care, 6 to 7% in Vicks, but actually even lower in saline. Saline had a lower incidence of headache than even usual care. So there's no real reason to use Vicks. If you like Vicks, fine. I used Vicks for a long time until we got the saline results. And now I use saline because it's cheap. You can make it yourself. There's the rub. You don't have to go on buying it's not expensive, but if you're using it regularly in the winter, you can make it easily yourself. And you find which of the spray manufacturers you can undo, put your own saline in, because usually it's easy to get isotonic saline. You can buy hypertonic saline in the web, and there is one version of hypertonic saline in the pharmacies at the moment, but it has extra additives. So so I've ordered it on the web, and actually I make my own hypertonic saline, and it's very easy. So 1 teaspoon in 250 mils of water is a mildly hypertonic solution, but make sure it's boiled because you don't want to shove tap water up your nose.
Excellent advice. Just one more kind of on sort of self-care side of things. One of our students was asking about, she's observed that sometimes people often promote about like honey and lemon use and things like that. Any evidence, anything?
There was it's a bit of a shame that you can't get. It's incredibly difficult to get money for these kinds of things. I mean, I'm amazed we got money for the saline trial, to be honest. But anyway, we did. Not complaining. But there was a small trial of honey in upper respiratory infections, and not a great trial, but at least some evidence. It's very lovely and soothing. Honey does have antibacterial effects, so if you think you've got a strep throat with high fever pain scores and you want to try something, yeah, honey's probably a good idea. Don't think there's any evidence for lemon, and there's no evidence for steam inhalations other than you might be more likely to scald yourself. So yes. I wouldn't just see. I mean, if you find you can do it and do it safely, fine. But it's the doing it safely that's the problem with steam inhalations.
Yeah, exactly. Thomas has got a question going back to sort of pharmacy first schemes. So they tend to direct their sore throats in adults to pharmacy first. Is there any evidence that community pharmacists prescribe more or less than we do? And then Kerry's actually responded saying there's been an evaluation of this in Wales, but I think she wondered if it might be a little bit of a different scheme there. But yeah, any comments on that, Paul?
Yeah, no, I think there's the is that Kerry Hood?
It is.
Hello, Kerry.
She's muted, I'm sorry, but yes, it is Kerry Hood. I can see in the chat.
Yeah, no, well, as Kerry knows very well, there's some nice observational evidence about pharmacists using it's test and treat service in Wales, which worked quite well. Not a trial, but I think probably it does work. It's always quite difficult making these comparisons. So the idea there is, when I was talking about, I think other near-patient test strategies need to be used. In essence, it says you're not going to get an antibiotic unless the test result is positive. And I think that's quite a useful strategy, and I think it's worth trialing at some stage if we can ever to get some money to do so. So that's what they've done, and observational evidence suggests it is probably effective. And probably lower than the average sort of GP, because GPs mostly don't use strep tests, which is fair enough. But if you're using, what we'd have liked to have done, I mean, what we showed is that when trials, pragmatically, adding in the strep test to the clinical score didn't make much difference. But I do think we need more trial evidence about the place of near-patient tests. And I think probably pharmacists are going to be a very good place, because as I said in our Grace trial, nice evidence for CRP. We trained GPs, they used it, fantastic effect, and then nothing after a season. You know, so do they work with a group of professionals who would use them consistently? I think they would probably work better than in the average general practice. So I think pharmacists actually might be a really important way forward to use these tests.
Probably time for one more comment. So Katrin, who asked the question earlier, just made a comment about when we're talking about the saline. Be interesting to see if people who use saline have more Staph aureus in their noses afterwards, given this bug loves saline and lives in the nose. It looks like they're a microbiologist and they're really enjoying the talk and discussion. But yeah, be interesting to see if they've got a lot of Staph A.
I think there is some evidence that you don't significantly alter the microbiome, but there isn't that much evidence about it. So again, you probably need to do that. In India, they've been using neti pots, which is sort of, or jala neti, I think they call it, for donkey's years, And as far as I know, they don't have problems with staph infections. So that's a cultural thing there. So as far as I know, there's no evidence that people get more staph infections, but we didn't find any evidence that people had come with staph infections, for example, in, well, 6,000 patients in our trial. There's been a trial in kids who might well be more snotty and have more staph, and I don't think they found anything either. But that's not to say that it doesn't happen occasionally, and maybe it will happen if people use them more regularly. We'll see. So that's an interesting idea.
So just coming to the end of our questions, I don't know if this is a bit of a big broad one to end on, but yeah, I was just really quite shocked by those World Bank estimates of 10 million of antimicrobial resistance related deaths by 2050, I think you said. Is there, you've talked about lots of things that, you know, areas where we might have more research in terms of sort of point of care testing and various other areas of research that seem to be underdeveloped, UTIs, etc. Is there anything that you can think it's sort of like a national policy change, or are you aware of in the next, you know, that might be coming in that you think will have a significant impact, or is that, yeah, a bit of a tricky one to answer?
Saline, Vicks First Defence. Oh, I should have mentioned there is some evidence for carrageenan spray. So carrageenan is another one of these polymers. Carrageenan is a seaweed extract used in food, has pretty minimal side effects, but some evidence that it can prevent and also reduce symptoms. So I think sprays are cheap, widely available, and they'll probably make more difference than anything else. So no, I mean, you know, maybe the World Bank's a bit over the top, but it is a problem, particularly if I think one of the real problems is that we don't know how reversible a lot of this is going to be. We think it is going to be. We've shown in some community studies it's not that reversible. So I think it's a problem. I think phages would be a fantastic thing. I mean, they're widely used in some countries. We just haven't ever got them off the ground. But I think phages would be a really important thing, because actually if we run out of antibiotics, so we need a pipeline of development of antibiotics, that's quite clear. And obviously there's market failure there, because companies have to spend millions developing antibiotics. And then if they've only got a very small market in the odd anti-ITU patient, then the return for them isn't worth it. So then there needs to be government, as in the COVID pandemic, there was government and industry working together. There needs to be government and industry working together in the pipeline for antibiotics. I think there's quite exciting things about using AI to predict what molecules might work for different bugs. I think the use of higher tech to speed up the development of useful molecules is likely to be important. So I think a combination of really simple things like saline sprays for people instead of using antibiotics. I think tech will help us a little bit, but I think one of the major problems is, even if we manage to reduce our antibiotics, it's a worldwide thing. So there has to be a worldwide push. So you get these horrible bugs coming in from places where there's over-the-counter use. And so that's got to be a big push worldwide to minimise antibiotic use over the counter access. Ease of over-the-counter access is a bad thing. Mm-hmm. So I think we all have to work together in our consultations, public health, and worldwide. And we are lucky. We now have some simple things that we know work and that will reduce antibiotic use.
Yeah, absolutely. And we've seen it work well, worldwide when we've had to come together before, in pandemic and whatnot. So with that, I'm going to bring the questions to a close, if that's okay. Thank you so much again, Paul. This is just a quick slide. Hopefully you can all see we really welcome and value your feedback as we continue to develop the series. So please use this QR code on the slide and it will link you to the feedback. And also, if you'd like a certificate of attendance, there's an option to request this when you complete the feedback form. So we look forward to seeing you again, hopefully on Tuesday, the 9th of December, where we'll be joined by Dr. Lewis Potter, who is the founder of Geeky Medics, talking us through his journey developing an online medical education platform and recent innovations in AI augmented clinical education. So please head to our website and register there if you haven't already. And as I said before, maybe I didn't say actually, all the seminars will be available online if you are unable to join live. So with that, thank you so much again, Paul. That was really, really fascinating. And we will let you all enjoy your evenings and yeah, see you again soon.
Bye-bye, everybody. Cheers.